What's going on, Dr. B?
Hey, how are you, Derek?
Good. I'd like to continue this discussion and going into what benzodiazepines are like. What is it like? However, before we get into that, you're doing something as somewhat a Mother Teresa style, the aspect of helping us addicts with harm reduction, going out on the streets and helping people by getting Narcan out to the addicts who are overdosing daily or sometimes weekly using this fentanyl heroin that we have out on the streets. Give us a little bit on that before we get into benzodiazepine.
Sure, it's actually really exciting for me. What I have, as I think you know, I have my aftercare program, PHP, IOP, and some sober living homes, and all of my organizations, they kind of have the same approach to care, and that approach is harm reduction, chronic care disease model, medication-assisted treatment, and professionalism. Within and my IOP program, American Addiction Institute of Mind and Medicine, it's a nonprofit. Within that, we started a subsidy of that nonprofit. It's called the Harm Reduction Institute, and it's run. The guy that runs it is a really outstanding, stellar medical student, and I have a team of medical students. And one of the things we do is they go out twice a week, and we have and this is all financed by ourselves. We go out and hand out hundreds and hundreds of Narcans, and they go to encampments, homeless places, all the places the homeless drug addicts live. And they've had, I think about, we just started it a month or two ago. We have about 30 documented. I like to use lives saved. The powers that be use the term opiate reversals, but I like to use lives saved. We have about 30 lives saved. We have this dedicated team of medical students doing that. We're getting our team really put together right now. Pretty soon in the back of my IOP, we're going to have tents 1 day a week. We're going to do hepatitis C evaluation and treatment. We're going to do referral to care. We're going to do STD education, and we're going to do kind of a case management for this population and hand out more Narcan. So I'm really excited about that whole thing that we're doing. And this is all, like I said, it's nonprofit. If we can, we try and get money to cover the cost, and that's about it.
That's awesome, Dr. B. That really is. I really appreciate you doing that, because I'm the kind of addict who did not have control. It had control of me. I needed help, and I didn't know a way. And someone like you, if I'd have known you 5 years ago, I can guarantee you that I'd have felt a lot better. I think I'd have had more of a chance and felt like there's a shot in this dark place called this world, and making it out to where it's the light shining, the grass is greener. Going to the topic of benzodiazepine. Benzodiazepine addiction and withdrawal is something that is one of the worst that I've heard in terms of trying to get off, not only because it's addictive in nature and very difficult, but that you can die coming off this stuff. So can you go into what benzodiazepines are like, what they're for, what's withdrawal like? Just kind of take us through the medication or that large group title, benzodiazepine, and then we'll get into some specifics.
We talked on the other thing about gabapentin, which hits GABA receptors. Benzodiazepines hit GABA receptors. Let me start off even making it more general. Benzodiazepines as a class fall under the class of sedative hypnotics. Under sedative hypnotics, you have alcohol, you have barbiturates, you even have GHB, the date rape drug, and you have benzodiazepines, and you have drugs that are called Z drugs, which are those drugs like Ambien, right? They're the sleep medications. They're a cousin to benzodiazepines. So that's the general class. So interestingly, benzodiazepines are alcohol in a pill. Now they all hit GABA receptors, different parts of the GABA receptors. Alcohol also hit other systems. They actually, by secondary and tertiary mechanisms, also hit your opiate system, and it's more complex. But for the most part, all of them hit these GABA receptors. What are GABA receptors? They're the inhibitory part of your nervous system. So you can think of it generally. Again, I'm taking all the research, all the science, and making this very simple, okay? when I say inhibitory, you have stimulants, whether it's cocaine or Adderall. That's a stimulatory effect on your nervous system. The opposite effect and the opposite system is an inhibitory system, and that's GABA, and that's benzodiazepines. They slow things down. Medically, what are they used for? Medically, what are they used for? Well, in surgery, you use it as a sedative before surgery to calm the person down. They also use them for a particular type of amnesia, forgetfulness, so you actually forget the surgery because, it's traumatic. You're about to go into surgery. If you remember anything, it sucks. Someone's cutting into you. So that's what the anesthesiologist, the guy that puts you to sleep, uses it for. Other uses of this medication are anxiety, sleep. Sometimes they're used for restless leg. They're used for obsessive compulsive disorders along with SSRIs, the reuptake inhibitors, the antidepressants. So these are the general things that benzodiazepines can and are used for medically.
Benzodiazepine addiction, what makes it so? Is it the chemical that makes it addictive and the fact that it does make one escape and feel this relaxation? And then what's withdrawal like trying to come off of it? How do you handle it as an MD?
The mechanism of abuse, misuse, and addiction is a little complex. One of the at the structural level, there's some sort of what they call an uncoupling effect. That means if you're using a benzodiazepine, the normal GABA piece that goes into that receptor no longer goes on, and so you need more and more benzodiazepines. That's at the structural level. At the psychological and clinical level, it's probably much more complex than that. I call it, a lot of physicians call it the hidden epidemic, and I just made a video about that, and I got some criticism about it, like, hey, it's not a big deal, but 95% of the people are like, this stuff's a nightmare. And I will say this, you see it oftentimes. Very few people start off with a benzodiazepine addiction nowadays because there's such a large substance abuse population, in particular opiates and alcohol. You often see it come in as a secondary substance of abuse and addiction in that population. You also see a lot of dependence in the elderly. I also think, people talk about doctors misprescribing opiates. Well, I feel that we have for a long time misprescribed this medication. Sometimes it was out of desperation, like how can I get this person to stop complaining for their issue? I think the doses we've used are too high and for too long. My position is that this is a short-term medication for 95% of the people, and you shouldn't use it more than 2 weeks and then move them on to something else or use psychosocial interventions. There's a few people, very few people, and I even have a couple of these guys that have been on it a long time, rightly so. And in that case, you have to evaluate the harm versus the benefit. The addiction and the physiological dependence is a nightmare. This class of drugs, sedative hypnotics, is the only class of drugs that the withdrawals can put you in the hospital or kill you, seizures, death. And the long and short-term withdrawals are horrendous. If you talk to someone coming off of this, and in fact, there's long-term withdrawals, and I hear people that were on it for years and years, and then they stop and they actually have issues for many years afterwards, whether it's anxiety, nightmares, even hearing voices. It's very difficult the longer you've been on it. Now, here's the little and if you want to ask anything more particular, ask me. I do want to convey this. The way the system is set up, most people are taper, detox, whatever you want, off this medication way too quickly. And it's really a cruel, harmful thing to do. It's painful and it's dangerous. And the system, when you go to a doctor, he'll oftentimes withdraw you off of this stuff for 2 weeks to 4 weeks. You go to detox, well, they're not going to get paid for months, so they're going to withdraw you off, regardless of how much you're on, what your age is, and how long you've been on. The key here, and I'm going to refer to a lady by the name of Dr. Ashton. She just died a few weeks ago. She was 90 years old. She was in the UK. She is the god of benzodiazepine tapers. Very few clinical trials, but thousands and thousands of papers published. Even World Health Organization uses her papers. And I have, for the most part, used her method. And I think you saw some of that in my clinic. What I do with my benzodiazepine tapers is very careful. Number one, my tapers can be anywhere from, depending on how long you've been using, could be anywhere from a month to 2 years. Okay, again, depends on the patient, their age, what they're on, how long they've been on. Number two, if you walk up to a patient who's been on, let's say, 4 milligrams of Xanax for the last 7 years, 2 years, 5 years, and has had all kinds of other issues, and they come in your office, you're like, you got to get off the Xanax. Watch their eyes light up, the horror in their face that you're going to cut them off. Doesn't work. I do something very particular. First, I build a rapport and make sure we trust each other and they trust me. And I make sure they're not abusing what they're on. They don't come to me and I have to get them off because I started them about 90, not 100% of the patients come to me and they've been on this stuff and they're just kind of, looking for something, whatever reason they come to me. So first I make sure you trust me. Then what I do is say, you know what? Once you trust me, we're going to have to get you off this stuff. You're 24 years old. You're 25 years old. You can't be on this for the next 20 years. It's going to blow your brains out. And there's long-term effects, and I'm not getting into any of this stuff. But once they have that trust, I'm like, please bring your bottle in once you come in next time. And let's say they're on 2 milligrams of Xanax twice a day. And I'll say, what's the date of that bottle? Okay, you gave it to me 2 days ago, and so it should last 30 days. So there's 60 of them. I'm like, okay, when do you take them? Well, for example, I take one at 10 a.m. and one at 6 p.m. Okay, so pull out 2 pills. Here's what I want you to do this month. You have 60 of them. I want you to do this. Tell me which dose is the one you need the least. Well, if I had to cut one out and if I was forced for it, but I can't, but I'm like, don't worry about it. Just tell me which. They get very paranoid. I'm like, just tell me which one you would need the least if there was one you could choose. They're like, okay, the morning one. All right, okay. So here's what I want you to do, Joe. Every day, I want you to try to cut that morning dose in half and put that second one back in the bottle. In 30 days, you're going to be here to see me. You would have either done it 30 days, so you should have 15 tablets, great. Or you should do it 0 days if you can't do a single day. And that's okay too. I don't care. I just want you here in 30 days and show me what you can do. Most of the time they'll do 1, 2, 3, 4, whatever. They come back and it's very interesting. They feel empowered, in control, and they realize they don't need this medication. Depending on where they fall on this scale, we start this game of empowering the patient over a long period of time, and we get there. But again, this is not what the system supports. The industry and the insurance companies, they're not like, hey, what do you mean you're doing this? This is how you're supposed to do it. This is the best data and evidence we have. Patients love it. It's safe. And when they go off the rails, which they rarely do, we address that. But that's how I do the taper for this medication. After, if I can get them to switch from Xanax to a long-acting one, because it's easier to do, then I go on this road and taper them in that way. And that's how it should be done.
That was really well said. I really, really appreciate that. And that's awesome that you do that, because I remember, just giving my subjective, if you will, with heroin, I was so terrified, even as it was an illegal substance on the streets. I was so terrified of abstinence. I really was. Like, though I did it, I'm here as a survivor, so to speak. And like, I'm a voice for many who don't take abstinent. And they're like, hold on, but you're abstinent. Aren't you one of those guys, right? You know, it's all or nothing, right? No, I'm not. I might have conveyed that message early on. I was also uneducated in the way that I am now. I'm learning a lot more, but I witnessed how you treated your patients. Of course, I won't disclose any more details than the fact that you really work very closely with your patients, and I hope more doctors do that, and I know there's some out there. Let's talk about differences between some of these benzodiazepine medications, because honestly, I don't really know. I remember my wife's grandmother, who passed away now. She was an awesome lady, but she was the drug dealer, okay? Like, she needed money, and so we'd go and pull some pills out of her purse and hand her some money, and she would have Valium, and she would have these other, Xanaxes and stuff, and we're taking them. My favorite was opiates, but we would take whatever we could get. And I wanted to ask you, we've got Xanax, Klonopin, Valium, and Tenazepam, or if I'm pronouncing that correct. Let's take one at a time. What do they do? Why Xanax instead of Klonopin? Why is it Xanax instead of Valium? Like, can you go into that detail a little bit?
I'll go a little bit. Let's even throw Librium in there, which is a very long-acting one that they use for alcohol detoxes. The differences between these is their potency, how quickly they get into your body, their volume of distribution in your fat cells, and how long they last in your body. And those different things can be sort of hijacked to use them for the most, let's say if someone has a panic attack, right? Xanax seems to be the appropriate thing to use because it goes into your body very fast and hits your brain receptors, okay? Let's say someone has, generalized anxiety. You might want to use a much more long-acting one like Klonopin, okay? So that's one thing to keep in mind. The second thing to keep in mind, there's a general theory that the quicker something comes on, the more abuse and addiction potential it has. That being said, of all of those, Xanax would have, and it seems to have from clinical experience and the data, the most abuse potential. One other thing, keeping this in mind, the effects you see with this stuff, you'll see everything from sedation, what's called hypnosis, which is putting you to sleep, but you also see at certain doses agitation, aggressiveness, and so forth. Think of alcohol. It's a sedative hypnotic. I can have a couple of glasses of wine and I have some sedation, I'm relaxed, I feel good, but let's say I have a tequila and you're like, hey, don't ever get me tequila, I black out and I don't remember. Don't you hear those same things from people that have the same issues with benzos and Xanax? So now go back to me saying it's alcohol and a pill. So those are the differences. And if you're a very careful clinician and use the right dose and understand those differences, you may be able to utilize them for certain issues that would fit best. And if you do, you need to keep a very close eye on the patient for abuse potential and addiction issues. And if they're using, and also, if they're using any other substances and so forth.
Thank you, Dr. B. Appreciate that. Ladies and gentlemen, if you have any ideas of what you'd like answered by Dr. B, make sure you go to his YouTube channel, hit that subscribe button, hit the bell, because he drops nuggets of information and he'll give you first-hand accounts of his patients, of course, leaving them anonymous. But nonetheless, the information is gold. If you're struggling with these things, reach out. You can get a hold of him. You can get a hold of me. Either way, we can help you guys get resources, get the help that you need, and try and get this treatment, because this is life or death when it comes to benzos. It's not a joke. I really appreciate you touching on this information, Dr. B, and I know that you're doing some great work out there getting people these Narcan shots. I'm a huge fan of what you do. I'm subscribed to your channel, so anyone who's watching my channel should be subscribed to you as well.
Derek, thank you so much. I'm a huge fan of yours because, number one, you're taking the abstinence route, yet you are absolutely objective about this, and you're one of the few people I know that's out there, and really you absorb these things and understand them really well. And I love the fact that you are yourself, you're non-judgmental, and you're very authentic, and you make that's why I love doing these with you, and I love connecting with you. You make a connection out there to all of these guys, whatever they're doing, however they're going about this, and it's really a diamond in the rough in our industry and what we do. So you're pretty awesome, and I'm hoping we do more stuff together here very soon.
We will. We definitely will. We plan on bringing a call-in show, ladies and gentlemen, so that you guys can come weekly or bi-weekly and call and ask questions or give us your circumstances. You can get Dr. B to firsthand answer them, and someone else might be struggling. You might help save their life because they were afraid to call, and they might be you. And that's what it's all about, the narrative, right? Let's save each other's lives. Let's have each other's backs, and let's help one another. My brother Kurt called me from the detox to where he's at right now, and he says, bro, this fighting this buprenorphine right now coming off, it's just the taper's too sharp, too quick. And I said, bro, jump on it for a few years. Work closely with your doctor. Get to a very comfortable dose. Get a job. Get your life together. Get good medical insurance. And in a couple of years, I'll make sure that you get into a good place where you can do a long taper or safely come off. But right now, he's like a cocoon butterfly, like a little, he's so fragile. You know, he just became a butterfly, or he's becoming one, and he's ready to take on the whole world. He's got stresses and everything that's coming. No. We need a better way. He needs to be protected. Even if that crutch is Suboxone, I don't look at that derogatory and I don't look at that negative. I know I almost relapsed so many times, and I know what it took for me to get where I am today. Very lucky, Dr. B. Very, or to some people, blessed. You could say there was divine powers looking after me. However, if you try to equate that, does that mean everybody gets swallowed by a whale and ends up in the depths of the ocean for 3 days and 3 nights? Does everybody walk on water? No. It's not something I want to see people die anymore of. Sitting on their couch, trying to do this by themselves in the dark, dying a lonely death because they tried to beat it, doing it abstinent. That's not the way to go. Get help. Reach out for help now before it's too late. And Dr. B's there for you guys.
Thanks, Derek. And you nailed it on the head with your brother. He cannot jump right back on the train of life. He needs to really understand where he's at and tell, I do know about your brother. We talk about him often. This is a very critical point you brought up, which I bring up with my patients. And like I said, it's amazing how insightful you are. And if you need anything from me, let me know.
Yes, sir. Will do. Hey, guys, don't forget, subscribe to this channel, subscribe to his channel, leave a comment. We're watching. We're waiting. Start typing now. All right, y'all.